Rahul, we can go live. Hello, everyone, and a very warm welcome to you all. My name is Simran Chaudhary, and it is my pleasure to welcome you all to the Voice of Healthcare's National Dialogue on Thalassemia Care, titled No Thalassemia Awareness, Action, and Advocacy, organized by Voice of Healthcare and supported by Hemex Health. Each year, World Thalassemia Day serves as a global reminder of the challenge faced by individuals and families affected by thalassemia. In India, where the burden of thalassemia is among the highest globally, it is crucial to raise awareness, promote early diagnosis, and strengthen policy around prevention and comprehensive care. And for the panel discussion, we are honored to have with us distinguished panel of experts who have been at the forefront of thalassemia care, research, and patient advocacy. Mrs. Shobha Tuli, Secretary Thalassemics India, a tireless advocate and change maker in the field of patient support and awareness. Welcome, ma'am. It's an honor to have you with us.
Hello.
Thank you, ma'am.
Yeah, thanks for your nice introduction, and I'm happy to be a part of this meeting.
Thank you so much, ma'am. Dr. Manisha Madkaikar, Scientist G and Director, ICMR National Institute of Immunohaematology, whose work has greatly contributed to advancing diagnostics and research capabilities in hemoglobinopathies. Welcome, ma'am. It's an honor to have you.
Thank you. Thank you so much for the invitation. Thank you.
Thank you so much, ma'am. Dr. Tulika Seth, Professor and Department of Hematology, All India Institute of Medical Sciences, New Delhi, a leading clinical expert with deep insights into thalassemia, treatment, and policy. Welcome to our show, ma'am. It's a pleasure to have you.
My honor. Thank you.
Thank you so much, ma'am. Thank you all for joining us today and lending your voice to this critical conversation. And now it is my pleasure to introduce our moderator for the session, Dr. Umut Gurkan, Chief Scientist, Microfabrication at Hemex Health and Professor of Engineering at Case Western Reserve University. Dr. Gurkan brings global perspective and a strong commitment to innovation in diagnostic and care of blood disorders. Thank you so much, Dr. Umut, for joining.
Thank you very much for the invitation, and thank you for hosting this panel today.
Thank you so much, Dr. Umut, and over to you to take this panel discussion ahead.
Thank you very much. This is such a meaningful panel discussion and webinar on this important day, recognizing the importance of thalassemia and raising awareness for action and advocacy. We are in a new phase when it comes to thalassemia, diagnostics, screening, treatments, and management of the therapy. There are many advances, and our experts in this panel will help us share all these new advances and the hope for thalassemia. And we have questions for each panelist, and we will go in order of these questions. And I would like to start the discussion by starting with the questions in this panel. The first question for our panelist, Dr. Manisha, is the following. What are the most promising recent advances and digital health approaches in the diagnostic and clinical management of thalassemia in India, especially in terms of point-of-care solutions and treatment protocols? Dr. Manisha, what are your comments?
Thank you so much. Thank you to Voice of Healthcare for this important webinar. I think in India it is very important to create awareness about thalassemia. In thalassemia, diagnosis if we want to talk of thalassemia diagnosis, it is diagnosis of the patients and it is screening. Screening becomes extremely important when we want to prevent thalassemia. So all the individuals who are of marriageable age should be screened before marriage, preferably for preventing birth of thalassemia children. And all antenatal women, especially those with low MCV and hemoglobin, must be screened for thalassemia. So, for patient diagnosis, the diagnosis is well set based on their clinical manifestations and CBC parameters. Then the mainstay is on HPLC and molecular diagnosis. But it is for screening that we are always looking for simpler tests which are cost effective. And for sickle cell anemia, now we have many point of care tests which have a good sensitivity and specificity. For thalassemia now, there has been one point of care test which is Gazelle, or based on, which is a semi-quantitative cellulose acetate paper-based technique. So this Gazelle has been recommended for thalassemia screening. But currently available platforms that we have in India, they are still semi-quantitative. Though it is used for sickle cell optimally, our experience in thalassemia antenatal screening is still limited. On the front of management, of course, now there have been multiple advances in the thalassemia care. We have right from good transfusion practices set to transplantation. Many thalassemia care has been optimized at multiple levels. And now recently we have ThalCare app, which is an AI-based tool to monitor the management of patients with thalassemia. So this app actually gives you reminders on a regular basis, monitors your healthcare records, and guides management of thalassemia patients. So this app, though personally I have not used, but it is there. Similarly, use of AI technology, similar use is going to be beneficial in future for patients with thalassemia. Thank you.
Thank you very much for your comments. What I'm going to do is, as we discuss these important topics, I will take notes and I will make a summary at the end of the panel. The next question is for Dr. Tulika. Considering the national guideline for sickle cell disease, how significant would a national guideline for thalassemia be?
So, guidelines are always important, and having a national guideline would be a big step forward. However, at the same time, guidelines are decided by the government. And in spite of not having guidelines for many diseases like thalassemia and hemophilia, we have excellent government policies and programs which are allowing the patients of many of these rare diseases and also thalassemia, which is a public health problem, to get very good access to care and treatment at both government and private hospitals. So, policy is always a goal that we all look forward to, but at the same time, we have to leave that to the government to decide. Uh, we do have very good guidelines at the moment, and these guidelines provide a good structure for care. And currently, these guidelines are being revised, and they form a great framework for uh, things like screening, prevention, as well as for management and long-term care of patients.
Thank you very much. Our next question is for Ms. Shobha. What community-led models have shown success in raising awareness and reducing stigma around thalassemia, especially among young couples and potential parents. How community screening and awareness campaigns help in rural and underserved communities?
First of all, I would like to thank Voice of Healthcare for involving the person from the community side. And as far as your question is there, and I will divide it into two sections. The first is that how the community-led models have shown success in raising awareness and reducing stigma. So as far as community, first I will talk about what are such activities which fall under these community leaders, fall which is the ambit of the thalassemia NGOs. So the activities which thalassemia NGOs normally do to raise awareness is to give the awareness talks in the school, colleges and corporates, and then is of course to put the hoardings and all that, and through the social media distribution of the pamphlets and giving ads in the newspapers, and then of course holding thalassemia screening camps and all. These are just the few activities that most of the thalassemia NGOs who have the resources are undertaking it in the different cities and the states. It is unfortunate that so far there is no such community driven or the government driven program launched till now, except in a few states, which is a state, since health is a state subject. So they are doing good work. But what is the need of this hour is to have a elimination thalassemia elimination program on a mission mode, as at what has happened in the case of sickle cell. So such activities are indeed helpful, but to a certain extent. As far as the stigma is concerned, I don't think so that I would like to comment at this point of time, because unless and until there is a full-fledged program launched by the government, whether it is in the state or by the central government, it's very difficult to make a comment here. But of course, I think looking at the number of population and the thalassemics that we have, and then the big population of our country, I feel that we have to be very very careful that we do not want any stigma to be attached to a woman. And as we all know that the marriages, most of the marriages take place in our country are not the love marriages but are the arranged marriages. And I'm very happy to share with you on this platform that recently I heard, and I heard it from Iran, that they have running a very successful program in Iran, which all of you must be aware of that. And what they have decided it that, well, first the men will be screened for thalassemia, and once it is confirmed that they are thalassemia carriers, then their women will be called. So I am looking at that if such kind of a program could be initiated in our countries, and especially in the largely populated countries, it might be helpful. As far as the rural and the underserved communities are concerned, I don't think so that we have reached to that extent that I am in a position to make any comment. But of course, our target should be first in the big cities, in the metro cities, such programs should be initiated. And whatever activities thalassemia NGOs undertake, they are not sufficient. It has to be a state-run program. It has to be a central-run program.
Thank you very much. Our next question is for Dr. Manisha. In your opinion, how accessible are curative therapies like bone marrow transplantation and gene therapy for Indian patients? And what are the barriers to scaling these treatments? Dr. Manisha, could you please unmute? Yes, thank you.
Currently, sorry. So currently we have two forms of curative therapies. One is stem cell transplantation, bone marrow transplantation, and gene therapy. While gene therapy is promising, unfortunately it is still not available in India. And as far as I am aware, I don't think any clinical trials are currently ongoing in this area for thalassemia. Though we have efforts on multiple areas to develop cost effective gene therapies for sickle cell anemia as well as thalassemia. And I hope that in near future we will have these therapies available at much lesser cost even in India. Now, coming to bone marrow transplantation or stem cell transplantation therapies, I think India is seeing a boost of stem cell transplantation centers in last couple of decades. Last one decade, especially last few years, multiple centers have come up all across India who can do bone marrow transplantation. And I believe the data was shared to me by Dr. Ratna that more than 4,000 patients have received transplantation till date in thalassemia from India. And even multiple transplantation centers in the government setup are required to improve or make transplantation accessible to everybody. The major hurdles for giving transplantation, doing transplantation in thalassemia patient in reasonably early in life is the availability of matched donor. Now, till recently, we didn't have a good bone marrow donor registry, but now even those are coming up in India. So I feel both fronts, the future is promising. I hope that there'll be a time that almost every thalassemia eligible patient will get a curative therapy in future. Thank you.
Thank you very much, Dr. Manisha. Dr. Tulika, the next question is for you. What are the key elements of palliative care for thalassemia major, and how should clinicians approach genetic counseling for beta thalassemia traits, especially in high prevalence underserved regions of India?
So, the WHO definition of palliative care is basically all the approaches that improve the quality of life of the patient as well as the family that is facing the life threatening illness. The major thing about palliative care is that in cancer, we kind of look at it as end of life care. However, in thalassemia, it should be part and parcel of the whole care journey of the patient. We want to focus on their quality of life, their symptoms, pain, psychosocial issues. We want to address and give support to the caregivers. We need to look at fatigue, nutrition. Often these are overlooked. So, palliative care principles must be applied to all of our patients with thalassemia to ensure that their quality of life is as optimal as possible. When talking about genetic counseling, I think it's really important to emphasize that this is not anybody's fault. Often in our country, we look at illness and other problems as, a part of your fate and your karma. And I think that's where sometimes we get into trouble. So it's really important to make sure that people understand that genetics is something that we inherit from our parents, and there's really no control over this. And if you have a mutation in your gene that makes you a thalassemia carrier, it does not mean that you are a patient. I have to keep emphasizing this to the families who come to me because often they feel that there's something wrong with a thalassemia carrier. So, thalassemia carriers are absolutely normal. And I often emphasize that it protects them from malaria, and they are not in any way inferior to anybody. It's actually a good thing. However, when two thalassemia carriers marry, then there's a 25% risk of having an affected child, even though they may have 75% chance of having a normal baby. So those are things that we need to emphasize, because sometimes a wrong message goes that, if both of you are thalassemia carriers, all your children will be affected, or you should not have children. So those kind of wrong messages sometimes get distorted in the community. So it's important to say that there's nothing wrong with it, but information is power. And if you have that power, you can take care of the future of your family.
Thank you very much, Dr. Tulika. Our next question is for Mrs. Shobha. How can patient advocacy groups partner with healthcare systems and policymakers to drive change in thalassemia care, prevention, and overall improving quality of life in thalassemia patients?
So It's very important for all the thalassemia NGOs and the community leaders to understand that they have to work hand in hand with the state governments and of course later on with the union government, because how much efforts they put in their work, whatever funds they have, the success will only come. And when I say success, it is towards the patient's care, cure and control. These are the three areas. So whatever efforts they may put in, if they are not working in hand with the state government, the results are not going to be effective and long lasting. And we have the few examples in front of us which I will share with you. That one is that, recently I'm just talking about in the last 2 years. The disability cards were earlier given issued in our country under RPWD Act for 1 year, and then it was extended to 2 years and 3 years. Recently, with the work of the advocacy, and of course, when we followed up with the ministry, and Madam Dr. Tulika is here, who was chairing that committee, and now the disability cards are issued on a permanent basis. That's one example. The second is that, as Madam has just mentioned, that we are into the revision of the 2016 guidelines on, especially for thalassemia. So, and another is that there was a national policy which was drafted. We have the Thalassemia Bal Seva Yojana project running in our country. Ayushman Bharat scheme, where the special thalassemia packages were drafted and made. Of course, there are many challenges that we have to address now so that it is available to all the patients countrywide. And then we have the inclusion of the RN chelations under the ETL, which is the essential drug list also. But it is important for NGOs that these things do not happen overnight, for which they have to work very, very hard. They have to make sure that their image is clean. They have to follow up with the state governments. They have to be in the best of the books in order to start a dialogue with the union government. So then there is, I don't think so that the NGOs, the community leaders, or the advocacy groups cannot succeed. But they have to make sure that they reach that stage where the government invites them to be a part of the communities, because the journey will start from there on. Thank you.
Thank you very much, Ms. Shobha. Our next question is for Dr. Manisha. How important is monitoring and evaluation of newborn screening programs? What are some of the indicators and best practices?
Actually, newborn screening is not really indicated for thalassemia. Currently, unfortunately, in India, newborn screening for common diseases is not universal at present. It is newborn screening for sickle cell anemia is definitely, or sickle cell disease has been something which is really important, because diagnosing sickle cell disease as early as possible and initiating comprehensive care in the form of antibiotic prophylaxis, folic acid supplementation, and monitoring them regularly significantly reduce their morbidity and mortality in patients with sickle cell anemia and sickle beta thalassemia. Beta thalassemia newborn screening usually is not indicated. As the patient becomes symptomatic, you can treat the patient. So, for sickle cell anemia, of course, different techniques are being used. And what is more important that we need to stress on is currently the government has initiated newborn screening for sickle cell disease in high prevalent states. But diagnosis, after diagnosis, the comprehensive care and its initiation needs to be stressed on. So I think that is from my side for newborn screening. Thank you.
Thank you very much. Dr. Tulika, what strategies need to be implemented to diagnose and manage sickle beta cases before they turn to severe forms?
So, in India, we have many regions where beta thalassemia is very common, and other areas where disease is common, as well as other hemoglobinopathies. So, earlier, there were clear regional areas which were known for sickle and known for beta thalassemia. But now we're seeing many patients who have this compound heterozygote state where they have both beta thalassemia as well as sickle. Now, amongst the beta sickle patients, also, there are two types. You have beta plus sickle patients, and these patients are a slightly milder group. And then we have beta zero sickle patients who behave just like sickle cell disease. The beta plus sickle patients have anemia, and they have the other symptoms that we would usually see in thalassemia, and they often have quite severe anemia and need blood transfusions. So this is the whole continuum of sickle and beta is seen in our country with both beta plus and beta zero. The only way that we can ensure that we identify these patients early is by doing testing. And this is where having a test that can pick up the beta component is very important, because if we're only identifying sickle, we will not identify that this patient has thalassemia as well. So, whenever we are doing confirmatory testing, it's very important that we do a proper test, either by a point of care test that is able to pick up the thalassemia component, or by an HPLC or other tests, to ensure that we are not wrongly labeling such a patient as only sickle when actually they have the beta thalassemia component as well. So, good, accurate testing, testing at the field, and early testing is very important so that we identify them and then we can prevent the complications.
Thank you very much, Dr. Tulika. Um, our last question is for Ms. Shobha. What are your views for the importance of CSR initiatives for thalassemia care and management from established firms?
Yeah, I'm very happy that you have come up with this question about the CSR funding and the CSR initiatives. On just a few days back, on 8th of May, which happens to be the World Thalassemia Day, so we have a Whole India had organized a very successful event at Ashoka Hotel, New Delhi, and this was to celebrate the gift of life. And this is a project which I want to talk about here. That they started it 7 years back. It was initiated in 2017. Until now, under this Thalassemia Bal Seva Yojana, more than 700 bone marrow transplants are being done. So, looking at the success of this, there were many, because it was in the press and all that, and a few corporates approached us and they showed interest that, well, they would like to do some projects jointly with us under CSR. So this is an area which all the thalassemia NGOs must explore and tap. And I believe the time is there that, well, it has to be whenever we look at the triple P model, and the success could be there because one of the people, the community leaders, have the experience of working to the grassroots level, and then we have a corporate with the funds and all that, and then we have a successful program. So one is on the cure side. Another thing which I want to share with you is that, well, for the last, I think for the last 6 years, we have been also under the CSR funding. We have a project by the name of Helping Hands Project. And I'm happy to share with you for that continuous 7 years, we have five corporates who have been continuously helping us to uh, to uh, to support the medical treatment of the underserved patients, and this funding has been coming to us regularly, just because we have been we have been submitting the documents on time, and they find us that, well, there is an NGO, and uh, who is looking into this area with the best of their abilities. So this is one area which I think which is very, very helpful if we have to go in for the further projects. And at this point of time, we have some corporates who are interested to work with us on the prevention side. So this is something which we all should look at that. And which I think through Voice of Healthcare and all that, with all the people who are here, all the experts, and they will all agree with us that this is one area which is something a very good area, and it has a potential, and all the thalassemia NGOs and the other areas from the hemoglobinopathies, so they should explore this side and try to do such joint projects under the CSR funding.
Thank you very much, Dr. Shobha. We actually have some um, questions from the audience. I would like to uh, take a look at them real quick and try to answer some of those questions. As you all know, there is a lot of interest on curative therapies, especially with the recent advances in sickle cell disease curative therapies and also success in thalassemia, especially on the CRISPR-Cas9 technology. The question from an audience member is how effective is CRISPR-Cas9 technology in treating thalassemia, and what are the current advancements or limitations in its clinical application? Any one of you can answer this question, and who would like to answer? Dr. Manisha earlier made comments about curative therapies. Dr. Manisha, would you like to take that question?
Sorry, actually, my connection, there was some disturbance. Can you repeat the question, please? Yeah.
Yes, it is also on the screen. How effective is CRISPR-Cas9 technology in treating thalassemia? And what are the current advancements or limitations in its clinical application?
Okay. So, there are multiple types of gene therapies for thalassemia. So, multiple in the sense either the gene therapy can correct the mutation that is specific for in a given thalassemia patient, or second therapy that they target is increasing your HbF levels in gene therapy. So both these therapies have been tried. I am currently not completely aware of the status outside, but it has been approved for therapy for thalassemia. So I assume that it is effective. However, for both these therapies, the the cost remains the major prohibitive factor, which limits its widespread use. And currently in India, it is not yet available. Dr. Tulika, maybe you will be able to, because Tulika madam is a clinician, and maybe she'll be able to add few things.
Yeah. So there is an approved CAS-GV is the name of the product. There is a product that is available which uses the CRISPR technology to increase the fetal hemoglobin in patients. It is approved and it's very effective. And as Dr. Manisha said, the cost is prohibitive, which is one of the reasons why we are not able to access this. I think it's about like 3 to 4 million US dollars, which is beyond the reach of most of our patients. The thing that I would definitely like to highlight, because a lot of our patients ask about gene therapy, but they need to know that this does not change their genetics. They can still pass on the genes to their children. So these things are important. And also, even though these technologies are there, we don't have extremely long-term data, like 15, 20 years data of these technologies, but definitely they are coming up. And hopefully in the future, in the next 4 to 5 years, we may have more information, and maybe the cost will also be more accessible. There is an indigenous program in India to look at CRISPR technology for sickle cell curative therapy, and that is being supported by the government of India.
Thank you very much for your comments on this question from the audience. Um, Organizers asked me to make a summary of the discussions, and then we have a story, a warrior story after my summary. So I will go to that next. Um, Here is a summary. I took notes as we discussed these questions and heard the answers from our expert panelists. I would like to just provide a quick summary and also maybe hear a few last comments or words from our panelists. Here's my summary. We discussed that we need much simpler and cost-effective screening and diagnostics methods that are needed for thalassemia. These technologies are currently being used in sickle cell disease, but their use in thalassemia is limited. There are also digital health solutions for thalassemia, such as apps and also some AI tools, but their use is also still limited. Um, my summary for this part of the discussion is there are technologies that are emerging, but they need to be put into better use to help us screen and manage thalassemia better. And there are things that we can learn from the successful sickle cell disease applications of such technologies. National guidelines are important, and as we know, they are set by the government. Having consistent and widespread policies is our goal for thalassemia, but we have to wait for the government to act on them and also put together these policies so that we can follow their guidelines and also um, uh, implement the existing excellent guidelines that are already present, which can happen with government policy. And government's role is very important in setting these policies and widespread use of those policies. Uh, in thalassemia, unfortunately, there is not yet an organized, widespread, community-driven and government program support that has been launched yet. And successful programs in sickle cell elimination can be a good model and example and starting points for thalassemia. And also, we must be careful not to attach any stigma for thalassemia, and because it can cause problems and misunderstandings and cultural dilemmas in the population. And we should also look at successful programs around the world. A successful program in Iran was given as an example, and we can learn from other screening and awareness and genetic counseling programs and bring some of those best practices here. We also discussed gene therapies and curative therapies. Unfortunately, as far as we know, there are no gene therapies or curative therapies or clinical trials that are yet available for thalassemia in India. Bone marrow transplant, which is also a curative therapy option, is available in India, and there are multiple centers in India that can provide bone marrow transplantation. And as far as we know, more than 4,000 patients have already received bone marrow transplants in India. One challenge associated with bone marrow transplants is finding the matching donors for these transplants. We all discussed that more work needs to be done to make curative therapies more available for all eligible patients in India. And our hope is that in the near future, these different types of curative therapy approaches, gene therapies, bone marrow transplants, and other emerging approaches would be available for all eligible patients. High cost of emerging gene therapies was also discussed. My personal opinion, there are many excellent research advances in India creating local, national curative therapy approaches, technologies is really feasible, possible, and it's already happening in other areas as I follow, especially in cancer, for example. CAR T therapy is now possible. It was developed in India, and maybe similar approaches can be followed here. We also discussed palliative care. principles which should be utilized for all patients with thalassemia, which would definitely improve their quality of life and health overall. It should not be limited to only a limited subset of the patients, and all patients would benefit from palliative care principles. Genetic counseling may have many cultural and personal meanings, and it is important to recognize that it is an inherited condition, and we should spend every effort to make sure that we don't have stigma associated with genetic counseling. And it is also important to emphasize that carriers are healthy overall, but there is a chance of passing the thalassemia gene to their children. And with genetic counseling, this could be provided as an education. We also discussed the the importance of patient advocacy groups and community partners. We commented that government programs would be better off working with patient advocacy groups and community partners, as well as also, in my experience, uh, researchers and clinicians and firms, companies that are developing new technologies or treatments would be better off working with patient advocacy groups and community partners early on to hear their perspectives and to find ways of implementing these new advances in thalassemia. Newborn screening is not currently being done in a widespread manner for thalassemia, and newborn screening in general for common diseases is not done in a widespread, in a national manner. But it is important to stress on the importance of screening, and not only screening, but we have to also keep in mind that after screening and diagnosis is done, management of the disease, treatment of the disease, providing options for management and treatment is also very important. So they go hand in hand, hand in hand. We also had an important discussion on the sickle beta thalassemia cases. In India, there are areas where thalassemia is highly prevalent and sickle cell disease is highly prevalent. But with recent screening program, we are observing that there are also regions, and in many regions, compound heterozygotes where you can have a beta thalassemia mutation and sickle mutation can happen. We discussed that there is a sickle beta plus version of this compound heterozygote state, which means that these individuals are relatively healthy compared to a sickle beta zero group, which is more similar to sickle cell disease. Um, only way to ensure, only way to identify these compound heterozygous cases where someone might have both thalassemia and sickle cell mutations. The only way to uh, ensure management is early screening and early management, so that these conditions can be properly managed. Uh, we kept emphasizing that early screening that is accurate and comprehensive is important, meaning uh, in the same screening program, if we can identify the sickle mutation and thalassemia mutation and others, some other common mutations, then we will be much better able to identify these more complex cases. So my personal suggestion here is these programs should um, carefully look at all these common mutations, sickle mutations, beta mutations in a much more comprehensive and in a much more widespread manner. So these are my notes. Is there anything that you would like to add or anything that I might have missed that you would like to emphasize? Maybe we can hear from each of you quickly. Thank you.
Uh, can I come in?
Yes, please.
Yeah, I think maybe I missed out. There was a mention about the donor registry as well, bone marrow donor registry as well.
Yes.
So that's one point. And my I one query from the experts that when we talk of newborn screening, especially for thalassemia, so what I personally feel coming from a patient advocacy group is that when we are going for screening and if we find a child, newborn screening, that the child is suffering from thalassemia major, okay. So what do we do next? This is just to identify because the birth has already taken place and the child has thalassemia major. So what I feel is that if we are trying to promote newborn screening for thalassemia, then the proper treatment regimes and all that should be, they should be, the support for the medical treatment should be in place. So how, if that is not in place by the government of India, because most of our patients are paying from their own pockets. There are some states, of course, who are looking after these patients and they are being supported by the state governments, but not all our patients are being supported. So I want to have answer and comment from your side, from the experts. Do you suggest, do you want to promote newborn screening for thalassemia?
May I comment first, and then I'll let Dr. Manisha give her comment. So, first of all, in beta thalassemia major, the treatment usually is not required many times in the first year of life. So maybe after 6 months, 9 months, sometimes even after the first year, the child may not be symptomatic. The earliest time that the patient can become anemic is usually around 4 to 6 months of age. So that is one of the reasons why newborn screening is usually not pushed too much, because in sickle cell patients, we want to start them on penicillin prophylaxis, while here we will not transfuse the patient or do anything until they actually develop the anemia, which usually occurs later once the fetal hemoglobin changes to the adult hemoglobin.
So you would not like to suggest, you are not in favor of the newborn screening for thalassemia?
For treatment, no. Dr. Manisha, would you like to comment on the diagnostic difficulties?
The newborn screening in general for thalassemia is not recommended. I also agree with that because, as Dr. Tulika said, mentioned that if you put in special efforts for diagnosis of only thalassemia in newborn period, that is not required. But India needs a concrete newborn screening program for 4 or 5 common diseases which are treatable or if you identify early, and which will reduce the morbidity and mortality. Newborn screening does not mean that you just screen the newborn and identify a disease. Newborn screening means you screen for a disease, trace the newborn, then guide the newborn to a nearest treatment facility, and all entire chain has to be complete. And this must be pushed for common diseases such as hypothyroidism, and maybe sickle cell anemia is one of them where we need to push. Currently, the techniques that are used for sickle cell diagnosis, both HPLC and the point of care test, will not accurately pick up thalassemia major child otherwise. So the currently that is also a problem. So we should not be pushing only thalassemia prenatal diagnosis, but as for all the common diseases, a common newborn screening program needs to be established in India. And I think together we should push for that concrete program.
Thank you very much for your comments on this important topic. Any last comments before we move on to the next stage?
I think everyone should know their carrier
And
status, and I
another,
think that's a slogan.
Dr. Tulika, could you please
yeah.
repeat what you just said? We didn't hear it very well.
Sorry, I was just saying that I think everyone should know their carrier status.
Mm-hmm.
And if we can get that awareness there, it's really important. I sometimes get these young boys who are coming for thalassemia carrier status detection, and I asked them, are they married? And they're no, we are planning to get married. And so there are these websites where they put on their things, so they're actually getting the test done for that. So I think that's a really good step, and we need more young people to come forward and be open and transparent and get their carrier tested.
Thank you
If
very
you
much.
want, if you want to have a comment on the management side, that I would like to come in,
Please.
because what I've seen is some of our patients, when they receive their recommended treatment, they're growing up, they're doing well in life, they have reached the age, even some of them have crossed 50. I know the numbers are very small, but these children, these adult thalassemics are very precious to us because they have traveled a long struggle in their life. Their parents have contributed to that, along with the doctors to whom they have been going for the treatment. But what I find at this point of time is that there is a time now that we have to look at that. One is the transition from the pediatric to the adult care, and the second is these adult patients have their different typical type of problems. One of the major problem is about the bone health, and then we have to use the technologies, high end investigations and all that, which are not in place of country. I'm not saying that India is far behind. What I want to say here is India has come a long way. We have covered a long journey where there was nothing. I will say that if we compare it with the underdeveloped world and all that, I think we have done much better than one could even expect. And when the countries talk about India, they talk very high about that what is available in our country. We have the best of the facilities for the bone marrow. What I want to share here is that it's time now that we all the expert doctors, and we have got full faith in our doctors and all that. We have to look at that what is the critical areas that our adult patients face, and what are the real high-end investigation that is required by these such patients. Of course, and now there are expenses involved, but these are the families I'm talking about who can spend their own money from their pockets. So these are the two areas. When we talk about the management side, I think they are very, very important. And it's time now. Some of the doctors and hospitals are working on to that, but we really have to push for this.
Thank
Yes.
you very much.
So, can I just say one last word? We've just started an adult thalassemia clinic, which will start in June. So, any patients who are interested, we're most happy to have them. And as Shobha ji and all are aware, the investigations at our center are mostly free of cost. And we look forward to helping our patients and collecting more information that can guide other doctors. Thank you.
Excellent. Thank you. Thank you for your last comments. This has been a wonderful panel. We had an excellent discussion on all the recent advances in thalassemia. There is definitely hope, and I also agree that India is way ahead in many areas, in technology, in treatments, in policy, national programs. But as we have discussed, there is also more work that needs to be done in thalassemia. Now, I would like to thank our panelists again for their expert knowledge and expertise, sharing your expertise with us. Um, we have a short video that we would like to play. This is actually by Mr. Bhuvi Uniyal, a beta thalassemia trait warrior. Now, I would like to turn the stage over to that video. Thank you very much.
Thank you. Thank you so much.
Thank you.
So, hi everyone, this is
Thank
Bhuvi
you.
Uniyal from Uttarakhand, and currently I'm residing in Dehradun. So, I'll be briefing you about my journey. So, back in 2018, when I was in college, I discovered about thalassemia, and this thing started with when I was a little bit sick due to, I guess, seasonal flu or something like that. And after that, जब मैं ठीक हुआ, then I started experiencing few difficulties like kabhi kavar what will happen is I will feel tired, skin got paler, and some few things that I used to it didn't suited me now. So I did all kind of sort of test and everything, and my treatment, I got treated in PGI Chandigarh. So they ran all sort of tests based even on addiction and everything, because that time what I was feeling is palpitations. A lot of palpitations were happening, irregular and everything. So they even asked me about, are you addicted or not. So from there they even tested the heartbeat and everything, and whether I have any heart problem or not. But at the end they did all sort of blood tests, and then they concluded that uh, I have beta thalassemia. And back then I didn't know anything about it, what thalassemia is, what beta thalassemia is. So to give you a short intro about short brief about it. So thalassemia is genetic disorder in which your red blood cells are not properly formed. They are kind of deformed. And as you know, there's red blood cell, then there's hemoglobin. So what happens is our red blood cells they are not properly formed. So the hemoglobins, the pigment, the thing that carries the oxygen, they don't bind well with the molecules and the red blood cell. So that's why based as compared to the normal human beings, we experience pale skin and even weakness and everything. So these sort of things. So based on my condition, sometimes, like most of people, those who have thalassemia experience these things, mood swings, and then there's continuous, जब आप फील कर रहे हो कि आप बहुत लो फील कर रहे हो, एनर्जी नहीं है, यू आर फीलिंग टायर्ड एंड एवरीथिंग. So all those sort of things happened with me. And then I started journey, to know my body more, कि धीरे धीरे मैं उसे एक्सप्लोर करूँ, how can I live with the body, because back then वो चीज़ मुझे बहुत खल रही थी कि I'm not normal, because I was also in NCC back in college. So NCC में आपको बहुत you have to do rigorous activities and all. So 1 month I was doing everything, running, cycling, push-ups and everything जो भी हम NCCs में करते हैं, drills and etc. And then few months later there was this regret and sorrow in me that right now, that from now onwards I won't be able to perform the way I used to do. So वहाँ से धीरे धीरे शुरू हुआ, and then I started exploring the body, like कहाँ पर I should put the line, कहाँ कैसा होना चाहिए. And I even wrote a lot of blogs on it. So I started hiking and everything back in 2021. So based on those things, I saw कि body को कैसे control किया जाए. Thalassemia है, but yeah, we have to live with it. And in 2021 I did Tune trek. After that I did treks within Himachal and Uttarakhand. So, and I regularly do treks now in Himachal, in Uttarakhand, and I also do a lot of cycling and everything. So जो मैंने experience किया, the thing is, first of all you have to accept the body, that there is something wrong with the body, and that's okay. A lot of people are, who have thalassemia, but उन्हें पता भी नहीं होता, because there is not much awareness about this topic, at least in India and even some Southeast Asian countries. So in our region particularly. So yeah, you have to know your body, and hydration and your diet is important. And अगर आपने ट्रीटमेंट कराया हो, तो आपको डॉक्टर्स ने कुछ सप्लीमेंट्स भी रिकमेंड किए होंगे जो आप लेना ही चाहिए आपको. फॉर एग्जांपल फॉर मी दैट्स होल 3 टैबलेट, जो मैं अब लेता नहीं हूँ बिकॉज अब नीड नहीं पड़ती, बिकॉज डाइट इज़ मोस्ट इम्पॉर्टेंट. आप डाइट में क्या ले रहे हो, लीफी वेजिटेबल्स वगैरह, एंड अगर आप नॉन वेज खाते हो तो रेड मीट वगैरह है या नहीं है. सो वो बहुत कुछ डिक्टेट करता है कि आप ओवरऑल कैसे फील करोगे. बिकॉज टायर्डनेस जो है, टायर्डनेस एंड वीकनेस इज़ द मोस्ट इंपॉर्टेंट थिंग जो हम फील करते हैं बार बार हो रही है, और हम एक्टिविटीज़ नहीं परस्यू कर पा रहे हैं जो हम करना चाहते हैं. फॉर मी इट वाज NCC एंड देन साइकिलिंग एंड हाइकिंग एज वेल. सो धीरे धीरे मैंने एक्सप्लोर किया कि बॉडी, हमें हमें अपनी बॉडी को एक्सेप्ट करना है, एंड वी हैव टू डू ग्रेजुअली एवरीथिंग. अगर आप कभी भी एक्सरसाइज कर रहे हैं, कुछ भी, ये नहीं कि आप एकदम से स्प्रिंट मार रहे हैं, या है ना वो सब चीज़ें, बिकॉज दीज एक्टिविटीज़ आर काइंड ऑफ लाइक मैराथन. आपको ऐसी एक्टिविटीज़ करनी है जहाँ आप धीरे धीरे अपनी एनर्जी जो है वो रिलीज़ कर रहे हो. एकदम से बर्स्ट ऑफ एनर्जीज होगी तो आप बहुत जल्दी थक जाओगे, बहुत टायर्डनेस हो जाएगा, जो मैं भी एक्सपीरियंस करता हूँ. सो दैट्स वाई वट एवर एक्टिविटीज़ आई डू, फॉर एग्जांपल हाइकिंग, आराम आराम से चलना है, वो हाइकिंग का प्रिंसिपल है ही है. एंड इवन साइकिलिंग, तो साइकिलिंग में ये नहीं कि आपका कार्डेंस बहुत ज़्यादा है, आप भगा रहे हो साइकिल या एम्प्टी भी हो गई, इजीली धीरे धीरे आप इंजॉय भी कर रहे हो, आपको अपनी बॉडी की लिमिटेशंस भी पता है, वो सब चीज़ें. सो दिस वाज ऑल अबाउट मी, the hiking and everything and better thalassemia. So diet is important जो मुझे लगता है अभी, and rest of course. Yes, so back then in college I used to sleep 5-6 hours, but अब ऐसा है कि बॉडी को 6-7-8 hours की तो स्लीप चाहिए ही चाहिए होती है, एंड कभी कभी इवन आई स्लीप 9 hours अगर मैं हाइकिंग पे हूँ या मैंने कुछ दिन पहले साइकिलिंग वगैरह किया. एंड रिकवरी टाइम इज़ ऑल्सो मच मोर फॉर अस देन नॉर्मल पीपल. जैसे कि अगर मैंने पिछले कल साइकिलिंग करी है 50-60 किलोमीटर्स, जो कि बहुत ज़्यादा होता है और मैं कभी कभार कर भी लेता हूँ उतना, बट देन फिर कुछ जो 2-3 दिन होंगे अगले, आई रेस्ट द बॉडी, उसमें मैं बहुत रेस्ट करता हूँ. और वो उतना बॉडी को लगता भी है कि यार रेस्ट चाहिए, है ना, बिकॉज हमारी बॉडी उस हिसाब से बनी नहीं है कि हम बहुत रिग्रेस एक्टिविटीज़ करेंगे, एक लिमिटेशन है ये. बट स्टिल आई कीप एक्सप्लोरिंग. टिल नाउ आई हैव बीन टू लॉट ऑफ ट्रैक्स एंड चैलेंजिंग एवरीथिंग. कुछ ऐसे ट्रेल्स हैं जो मतलब 4 दिन की आइटनरीज थी, बट आई डिड इन 2 days जस्ट फॉर एक्सपीरियंसिंग कि यार बॉडी कैसे रिएक्ट करेगी. एंड currently I'm pursuing more of that. I want to do some high passes and treks which touch the height of like 5,000 meters. The max I have been currently was 4,800 meters. That was in Ali Bedni Bugyal, and there is a place called Patanachuni. From there we go for Rukun trek. And Tapovan, Gomukh Tapovan trek, the birthplace of river Ganga. So Tapovan is around 4,500 meters. So these are the highest places I have been to currently. But now I want to challenge myself कि मैं around 5,000 meters easily क्रॉस करूँ, to see कि बॉडी कैसे एक्सपीरियंस कर रही है या क्या रिएक्ट कर रही है. So for that I have chose some tracks. For example, there's Kedartar trek in Gangotri National Park, and then there's Rupkund trek, yeah, the famous Rupkund trek. It's currently banned, but let's see कि फ्यूचर में वो ओपन अप हो या ना. और भी बहुत सारे 5,000 मीटर्स के ट्रैक्स एंड हाइक्स तो नहीं कहेंगे, बट या हाई पासेज हैं जो मैं करना चाहूँगा. एंड देन द नेक्स्ट गोल आई हैव इज़ 100 kilometer of cycling in a day. So these all are the things that I'm doing and I'm experiencing, है ना, and taking notes of the कि क्या मैं फील कर रहा हूँ, कैसे मुझे अब करना है, डाइट क्या होनी चाहिए, कितना रेस्ट लेना चाहिए, क्या क्या लिमिटेशंस हैं हमारी बॉडी की जो हमें एक्सेप्ट करना ही है. सो दिस वाज फ्रॉम माय साइड. थैंक यू.
I would like to thank our beta thalassemia warrior. As we have heard, it is possible to live a limitless life even if you have the beta thalassemia trait. It was an excellent, wonderful story. I also would like to thank our panelists for sharing their expert knowledge and experience with us, and thank you all to the audience who joined us today. Um, to listen to these recent advances and discussions on thalassemia. I would like to thank again, and this concludes our session today. Thank you very much.
Thank you.
Thank you.
Thank you.
Thank you.
Thank you very